World Medicine Universitet. 2017. Lasers and similar devices in the treatment of acne vulgaris. In addition to the numerous medical therapeutic options available for acne vulgaris introduced in the previous chapter, multiple lasers and laser-like devices have been found to be of substantial clinical value in the treatment of this common condition. The devices and techniques described in this chapter now have a considerable track record of clinical efficacy and safety, and may be used alone or, for the best results, concurrently with medical therapeutic agents. Mid-infrared range lasers. Originally developed for non-ablative photorejuvenation of the skin, several mid-infrared lasers have subsequently been found to be of significant use in the treatment of acne vulgaris, 2021, and, as will be discussed in the next chapter, acne scarring. These include the 1320 nm neodymium yttrium aluminum garnet laser, the 1450 nm diode laser, and the 1540 nm ytterbium-erbium phosphate glass, also known as erbium glass laser. Table 2. Mechanism of action. Although the exact details of the mechanism of action of mid-infrared lasers in the treatment of acne vulgaris have not been elucidated, ongoing research is being performed. All three wavelengths are well absorbed by water, resulting in bulk heating of the dermis as heat is propagated from the dermal water content. 22. The laser beam emitted by each of the three systems is known to penetrate to the level of the sebaceous glands in the skin, typically located at 201,000 μm below the stratum corneum. Of note, light at 1320 nm is least absorbed by water and, consequently, has the greatest optical penetration depth in the skin, defined as the depth at which laser energy is attenuated through absorption and scattering to 1/e, or approximately 37%, of the original value. From the study of the 1450 nm wavelength, it appears that at least one mechanism of action of the mid-infrared lasers may be functional, if not structural, alteration of the sebaceous glands. In the study by Pathankar et al., thermal coagulation of the sebaceous lobule was demonstrated in rabbit and human skin immediately following laser irradiation. Biopsies obtained from human subjects at 2 and 6 months following treatment, however, showed normal sebaceous glands and ducts, suggesting eventual regeneration of these structures. It was suggested, then, that such temporary structural alterations may induce functional changes in the sebaceous glands and, possibly, sebum production and composition. These proposals remain speculative, and recent studies of sebum production following laser treatment have provided inconsistent results. Future studies will need to identify additional factors that may be contributing to the improvement in acne lesions seen with these lasers. Treatment specifics. As with all light-based treatments, proper patient selection and pre-treatment care are important. In the therapy of acne vulgaris, both facial and truncal involvement can be improved with these devices. 23, 24. Although most studies have documented improvement in inflammatory acne lesions, one study noted a transient reduction in open comedones, suggesting a potential benefit in such a population. Patients with acne scarring may derive an additional benefit of improvement in their scars, as will be discussed in the next chapter. Although light absorption by epidermal melanin is low throughout the mid-infrared range, it is approximately 1.6 times higher at 1320 nm than at 1540 nm. It has, therefore, been proposed that the latter wavelength may be slightly safer in darker skin tones. Nevertheless, studies indicate that all mid-infrared lasers may be used safely in all skin types, provided that proper laser parameters and epidermal cooling are utilized. 25-26. Immediately prior to treatment, all makeup needs to be removed to prevent inappropriate absorption of laser energy and subsequent epidermal overheating. The addition of microdermabrasion prior to treatment has not been shown to improve clinical results, at least with the 1450 nm laser. Mild to moderate pain may be experienced with some devices, especially when higher fluences are utilized, and topical anesthetics may be used based on patient preference. Finally, eye protection needs to be provided in the form of goggles for the practitioner and goggles or gauze for the patient. Since mid-infrared lasers are able to penetrate deeply into the skin and are non-specifically absorbed by water, epidermal damage is an important consideration with these devices. Thus, the use of these lasers without their associated cooling devices may result in epidermal necrosis. Early 1320 nm lasers equipped only with a pre-pulse cooling led to an increased risk of blistering, hyperpigmentation, and atrophic scarring. As a result, all currently marketed mid-infrared range lasers feature continuous or pulsed epidermal pre-, intra-, and post-treatment cooling. Depending on the device, this is accomplished with either contact cooling using a chilled sapphire window, or a liquid cryogen spray, also known as dynamic cooling. In addition, the 1320 nm laser is now also equipped with a thermal sensor to maintain the peak epidermal surface temperature within a defined range, typically 40–45 oC. Considering the importance of epidermal protection, a given cooling system must be tested immediately prior to treatment. The 1320 nm ND-YAG laser features a 10 mm spot size, a fixed, 50 millisecond pulse duration composed of 6 stacked pulses, and an adjustable fluence. The handpiece contains 3 portals, including the laser aperture, cryogen spray aperture, and a thermal sensor. In the treatment of acne, the initial fluence is typically set between 12 and 18 J/cm2. A test firing is performed and fluence is then adjusted to reach the required temperature range, as displayed on the light-emitting diode screen. 3 to 4 passes are usually undertaken, although no randomized controlled trials have been performed to document greater efficacy of multiple passes in the treatment of acne vulgaris. Pre-, intra-, and post-pulse epidermal cooling is achieved with 3 pulses of a cryogen spray. It should, however, be noted that cryogen may in turn cause cold injury to the epidermis, leading to post-inflammatory hyperpigmentation in darkly pigmented individuals. Cryogen delivery time should, therefore, be shortened in such cases. The 1450 nm diode laser features a 4 mm or a 6 mm spot size and an adjustable fluence. The laser pulse consists of 4 stacked pulses totaling 210 millisecond, which are interspersed with 5 cryogen spurts to provide pre-, intra-, and post-treatment epidermal protection. Typical fluences used with this system range from 9 to 14 J/cm2. Fluences higher than 14 J/cm2 have been found to cause more pain without improved efficacy. In a recent study, a double pass technique was compared to a stacked pulse technique, and found to cause less pain and carry a lower risk of hyperpigmentation in darker skin tones. The 1540 nm ER glass laser features a 4 mm spot size, pulse duration of 3.3 millisecond, and continuous contact cooling using a chilled sapphire tip. This cooling mode results in a generally less painful treatment and more tolerable experience compared to the other mid-infrared devices. The laser can be used in normal, single pulse mode, or pulse train mode with up to 3 pulses/second. Typical fluences range from 8 to 10 J/cm2 per pulse and a cumulative fluence of up to 60 J/cm2 in pulse train mode to prevent epidermal damage. Because of their non-ablative nature, mid-infrared lasers typically do not require specific postoperative care. Common adverse effects may include mild to moderate transient pain and mild erythema and edema that resolve within 24 hours. Blistering, post-inflammatory hyperpigmentation, and, rarely, scarring, are uncommon and may be related to high fluences or excessive cryogen cooling, especially in darker skin types. Maximum improvement in inflammatory acne requires multiple treatment sessions, typically 3 to 6, administered every 2-4 weeks. Thereafter, periodic maintenance treatments may prolong the overall clinical improvement, although specific retreatment protocols have not been established. All mid-infrared range lasers appear to have similar clinical efficacy in the treatment of acne. It should, however, be noted that no face-to-face comparisons of the different systems in the treatment of this condition have been published. Pulsed dye lasers. The first randomized controlled trial on the use of pulsed dye lasers in the treatment of inflammatory acne vulgaris was published in 2003. The study utilized subpurpuric doses, resulting in significant reduction in total and inflammatory acne lesions, 49% in PDL treated versus 10% in sham laser treated patients with a low incidence of adverse effects. A later study, however, failed to show significant improvement in facial acne using the same device, though the study included a large number of dropouts, potentially introducing type 2 errors. 2 recent studies showed that the improvement following PDL treatment is similar to that achieved with a chemical peel or topical preparations. Currently available PDLs usually operate in the 585–595 nm range and may or may not include cooling mechanisms. Mechanism of action. A study on the potential mode of action of PDL on inflammatory acne revealed no effect on either Propionibacterium acnes counts or sebum excretion rate. The study noted, however, a significant 5 to 15-fold increase in the expression of transforming growth factor beta mRNA. This cytokine is known to be a potent immunosuppressant, as well as an inhibitor of keratinocyte proliferation, an important factor in the formation of microcomedo. Treatment specifics. Prior to treatment, the patient should remove all makeup. Proper eye protection has to be worn by the patient and all personnel during treatment, as the emitted wavelength is readily absorbed by the retina and retinal vasculature. Subpurpuric doses can be achieved with either lower fluence or longer pulse duration. In addition, fluences may be further lowered in patients with darker skin tones. If available, epidermal cooling may lessen patient discomfort and the risk of dyschromia. Used at subpurpuric doses, PDL treatments carry a small risk of transient adverse effects, including pain, focal purpura, pruritus, and dyschromia. In addition, a case of ophthalmic herpes zoster following the procedure has also been reported. Although the original study on the use of PDL in inflammatory acne employed a single treatment, other clinical trials have used other regimens, such as multiple sessions administered 2 weeks apart. Thus, the optimal treatment protocol, including the need for maintenance therapy, has yet to be established through further studies. Visible light sources and light-emitting diodes. Visible light sources were some of the earliest light-based systems used in the treatment of acne vulgaris. Originally, blue light devices were introduced and subsequently gained FDA approval for the treatment of this condition. Later developments in this field include the advent of blue and red LED panels, with the latter device used off-label in the US for this indication. Mechanism of action. The use of visible light in the treatment of acne vulgaris takes advantage of the intrinsic production of porphyrins, most notably coproporphyrin 3 and, to a lesser extent, protoporphyrin 9, by Propionibacterium acnes. Activation of porphyrins in the presence of an oxygen molecule produces singlet oxygen species, which is highly reactive and leads to cellular destruction of the bacterium. The major absorption peaks for coproporphyrin 3 are 401 nm and 548 nm in the visible light spectrum, whereas those for protoporphyrin 9 include 410 nm, 505, 540, 580, and 630 nm. Although the absorption peak is significantly higher in the blue portion of the light spectrum, the associated wavelength has very limited penetration into the skin. As a result, additional light sources, such as those emitting red light with greater optical penetration depth, have also been used for porphyrin activation and subsequent elimination of P. acnes bacteria. Additional mechanisms may be involved in the improvement of acne vulgaris by visible light sources. Blue light has been found to reduce significantly the expression of interleukin-1 alpha and intercellular adhesion molecule 1 in response to inflammatory cytokines, thus acting as an anti-inflammatory modality. Likewise, red light at 635 nm has been shown to possess anti-inflammatory qualities, including decreased expression of phospholipase A2 and cyclooxygenase and synthesis of prostaglandin E2. Treatment specifics. Visible light sources can be used in patients of all skin types with facial or truncal inflammatory acne, 27, 28. In addition, a reduction in the number of comedones has also been noted with the use of blue and combined blue and red light sources, although such findings have been inconsistent. Immediately prior to treatment, all makeup is removed and the patient's eyes are protected using goggles or gauze. Treatments are not associated with any significant discomfort, obviating the need for topical anesthesia. Although the number of clinical trials, both randomized controlled and case series, utilizing visible light sources is fairly large, optimal treatment parameters have not yet been established. Blue light sources on the market today utilize a variety of spectral outputs, such as 405 420 nm, 415 nm, and 417 nm. Red light sources typically vary from 633 to 660 nm. Most regimens utilize twice-weekly treatments for 4 weeks, although some studies included daily treatments, while others alternated exposure to red and blue lights during the twice-weekly sessions. Likewise, optimal exposure times have not been established, with most studies utilizing a 16-20 minute exposure, with shorter exposures of 10 minutes and even as low as 35 seconds also shown to be effective in the treatment of acne. These parameters will need to be optimized through additional studies in the future. No specific post-treatment care is required following exposure to visible light devices. Adverse effects are uncommon with visible light therapy, but may include mild erythema, xerosis, pruritus, acne flare, and headaches. Photodynamic therapy. Photodynamic therapy utilizing 5-aminolevulinic acid in combination with a specific blue light source is currently FDA approved for the treatment of non-hyperkeratotic actinic keratosis on the face and scalp. It also has a long track record of being used off-label for the treatment of acne vulgaris. Additionally, methylaminolavulinate, a methyl ester form of ALA, has long been available outside the US for similar indications. It has recently gained FDA approval for the treatment of actinic keratosis, but is not yet available in the US. Mechanism of action. Although several potential mechanisms of action of PDT in acne vulgaris have been proposed, they have not yet been definitively proven. Hongtru et al., who pioneered the use of ALA-PDT in the treatment of inflammatory acne, noted decreased sebum production, suppressed bacterial fluorescence, and reduction in the size of the sebaceous glands following treatment. These effects are thought to be the result of the direct action of ALA on the sebocytes and P. acnes bacteria. However, additional physiological mechanisms may also be involved, but have yet to be demonstrated. ALA is part of the porphyrin pathway. When applied topically, ALA accumulates in rapidly dividing epidermal and dermal cells, as well as within the sebaceous glands. It is then converted to protoporphyrin IX, which is photosensitizing and, as was described in the previous section, leads to the formation of singlet oxygen species upon activation by light. This, in turn, causes cellular membrane disruption and damage to the affected cells, such as to the sebocytes. The mechanism appears to be slightly different within P. acnes bacteria, as the addition of ALA to the bacterial culture leads to a greater intracellular accumulation of coproporphyrin III, which, as was described in the previous section, also leads to the formation of singlet oxygen species and may lead to bacterial cell death. As mentioned before, PPIX has multiple absorption peaks, including 410, 505, 540, 580, and 630 nm. Consequently, various lasers and light sources can and have been utilized in PDT for acne vulgaris. However, the longer wavelengths with their enhanced optical penetration depth may be better suited to reach the level of the sebaceous glands within the skin. Treatment specifics. PDT for the treatment of acne appears to be safe in all skin types, although the published controlled trials and case series have been mostly limited to skin types IV. Patients with mild to severe inflammatory and cystic acne with facial and truncal involvement are best candidates for this therapy. 29-30. However, activation using a long-pulsed dye laser has recently been shown also to reduce comedonal lesions. Prior to the application of topical photosensitizers, the treatment area is cleansed and preferably degreased using an acetone scrub or microdermabrasion to increase cutaneous penetration. Recently, fractional resurfacing immediately prior to PDT has been successfully used in photorejuvenation and may theoretically also be of use in the treatment of acne. The only currently available formulation of ALA in the US is a 20% solution in a single-use applicator. The solution has to be mixed immediately prior to the application by first applying manual pressure onto the outer glass tubing of the applicator to break the inner ampoules containing the active ingredients, followed by gentle rotation between fingers for 3 minutes to assure adequate mixing. The roll-on applicator tip is then used to apply the chemical evenly over the treatment area. As was mentioned above, a slightly different photosensitizer, MAL, is currently only available outside the US. It is supplied as a fixed cream formulation containing 16% of the active ingredient, which is applied directly over the treatment area. This use is supported by several clinical trials, which indicate that MAL-PDT is effective in the treatment of acne vulgaris. Moreover, in a direct comparison of ALA-PDT and MAL-PDT, the clinical improvement was found to be similar between the two groups, whereas a greater incidence of erythema, pustular eruptions, and exfoliation was noted with the former technique. Attempts have been made to optimize incubation times following ALA or MAL application in order to allow adequate penetration while shortening the overall duration of the procedure. While earlier studies typically allowed 3 hours of incubation, more recent evidence suggests that shorter incubations of less than 1 hour, sometimes as little as 15 minutes, may be adequate in the treatment of acne. Multiple lasers and light sources have been used for the activation of topical photosensitizers used in the PDT of acne vulgaris. These include lamp and LED sources of red and blue light emitting diode lasers, intense pulsed light, long pulsed dye laser, and combined non-coherent light and radio frequency device. Although not currently supported by extensive published data, a recent consensus statement suggested that the best results in the PDT of acne may be achieved with the use of a pulsed dye laser as an activating device. Typically, when using lasers or intense pulsed light devices for activation, one or more passes of non-overlapping pulses are administered over the treatment area. On the other hand, when blue or red lamps and LED devices are utilized, exposure time is usually set at 15-20 minutes. This stems from the original protocol for the treatment of actinic keratosis, which called for 16 minutes and 40 seconds of blue light exposure. However, no studies determining the optimal exposure duration in the treatment of acne have been published. Following the procedure, a mild cleanser is used to remove any remaining ALA. Alternatively, a source of blue light may be used for 5-8 minutes to deactivate the remaining superficially localized photosensitizer in a process called photobleaching. A broad-spectrum sunblock is then applied and patients are instructed on the complete avoidance of direct exposure to sunlight for 24-48 hours due to an increased risk of a phototoxic reaction. While most patients tolerate the procedure very well with minimal to no discomfort, short-term adverse effects of PDT in the treatment of acne vulgaris may include mild to severe stinging, burning, or pain during the treatment, transient mild to severe erythema, edema, urticarial wheals, exfoliation, crusting, transient dyschromia, and acneiform pustular eruptions, 31-36, 34-36 overleaf. Ice packs and mild topical steroids may improve localized symptomatology, while prolonged incubation times may cause more severe reactions, known as the PDT effect. Additionally, the specific activating systems may carry their own potential adverse effects, such as purpura associated with the use of a pulsed dye laser or incidental hair removal in the areas treated by an intense pulsed light device. 1 to 4 treatment sessions administered in weekly to monthly intervals have most commonly been used in the published studies of PDT in acne vulgaris. However, the optimal treatment schedule and the need for maintenance therapy have not yet been firmly established. Radiofrequency devices. Recently, radiofrequency systems have been successfully tried in a very small number of studies on the treatment of acne. Mechanism of action. Monopolar RF systems feature a single electrode and a large grounding plate attached at a distance, whereas bipolar RF devices are equipped with two electrodes separated by a short distance. Both types of systems produce electrical flow, either between the two electrodes or between the electrode and the grounding plate. According to Ohm's law, this flow, or electrical current, increases with decreased tissue impedance. As per Joules's law, such current also produces heat in direct proportion to the impedance, and volumetric tissue heating, expressed in J/cm3, is subsequently achieved. It has been proposed that such tissue heating may damage sebaceous glands, which may be further aided by the addition of intense pulsed light in some systems. While histological examination of biopsy specimens confirmed a decrease in the size of the sebaceous glands following treatment and demonstrated reduced perifollicular inflammation, the current knowledge of the potential mechanisms of action of these devices in the treatment of acne vulgaris is very limited. Treatment specifics. In one study, a monopolar device equipped with pre-, intra-, and post-treatment cryogen spray cooling was used in conjunction with either a 1 square centimeter or a 0.25 square centimeters electrode tip and energies ranging from 65103 J/cm3. 1 to 3 sessions were used and no adverse effects other than intraoperative mild to moderate pain were noted. Additionally, improvement in acne scars was also noted in some patients. In a separate study, a bipolar RF device combined with a broadband pulsed light was used in conjunction with contact cooling, optical fluences of 610 J/cm2, and RF energy of 1520 J/cm3. Patients were treated twice weekly for 4 weeks. No long-term adverse effects were noted, while mild intraoperative discomfort, transient erythema, and 3 cases of first-degree burns were recorded. Because of the small number of available studies, the effectiveness of the presented treatment protocols, potential adverse effects, and the duration of clinical effect cannot be properly evaluated at this time. Future studies will need to establish the clinical utility of RF devices in the treatment of acne vulgaris. World Medicine Universitet. 2017.